Bring up our next speaker. We'll shift gears a little bit. Dr. Graham Fedorak, one of my local colleagues from Kapiolani Medical Center. He did his training at Queen's University in Canada and his fellowship at Shriners, Los Angeles. He'll give a talk on early onset scoliosis treatment options, surgical and non-surgical. So thank you.
Thanks. That was a wonderful talk, Dr. Lahner. I don't think releasing a tether is necessarily a failure, but we have to categorize it as that, especially for the thoracolumbar kids. It's a quick and easy thing to do and saves them a fusion. But I'm a pedipod, so every time I get into the lumbar spine, I start feeling a little bit queasy about fusing it. Jumping right in, I'm a pedipod here in Hawaii at the Children's Hospital at Kapiolani. I spent some time in Utah at the University of Utah and just want to acknowledge my mentors there in teaching me what I know about early onset scoliosis. These are a couple of my patients that I was treating for idiopathic EOS. They were both being casted. They went to the same church. There's a lot of kids with early onset scoliosis in that community. So starting, we should always talk about the CEOS, or the classification of early onset scoliosis. It's only been around for the last 10 years or so, but I think it's really facilitated research and communication. A lot of old studies on EOS would lump everyone together, and we know that these kids are really heterogeneous, and we need to treat them all a little bit differently. Remember that idiopathic is a diagnosis of exclusion. With advanced imaging or a little diagnostic persistence, you'll often find another underlying etiology. MRI is going to be indicated in most of these kids, less than 10 that show up in your clinic. You'll find up to a 25% rate of intraspinal anomalies on presumed idiopathic kids. I'll often skip it in some CP kids or some neuromuscular etiologies. This patient's family attributed his very severe deformity to having fallen out of a coconut tree when he was a kid in Samoa. So this is just a great example. Healthy kid with a pretty small curve, normal neuro exam and history, who has a big syrinx and a Chiari malformation requiring neurosurgical decompression. The workup also has to include the cardiac and the renal system for those kids with congenital EOS. Remember to get an echo, a renal ultrasound, not just spine doctors. If you're taking care of kids, you got to think about those other things as well. This is a kid with a fully segmented hemi, presented prior to a year of age, sent him for an echo, and he ended up with open heart surgery. So you need to cross your T's and dot your I's. So EOS is different from our kids with adolescent idiopathic scoliosis and also the patients with adult deformity, because untreated, it's really going to shorten the lifespan. Those two boxes on the left, the infantile and juvenile groups, would be our EOS population now, and you can see the dramatic difference between observed and expected deaths. So this is primarily because of thoracic insufficiency syndrome, characterized by Dr. Campbell as the inability of the thorax to support normal respiration and lung growth. It's not all about the spine. Our primary goal is really to mitigate that TIS. In order to do so, you have to know how to control the deformity, but you also have to understand how the spine's growing, the growth of the thorax, and pulmonary development. In particularly, alveolar hyperplasia is only going to occur until the age of 7 or 8. So if you're not making the box bigger before then, those kids might not have the opportunity to develop new cells which can subsequently grow. So very, very condensed history of 40 years of EOS surgery. Early on, it was a fusion in situ, often without attempts at correction. This seminal study from the TSRH gave us this number of 18 centimeters of thoracic height as being a useful threshold. A PSSG, or Pediatric Spine Study Group study from a couple of years ago showed only 2/3 of kids were actually getting to this threshold. And Dr. Johnston published a paper in JBJS Open Access a few years ago, really saying this number is not the be-all and end-all. The spinal deformity is a huge factor. There's a lot of other things going on, and we shouldn't be using this as a success or failure threshold. A lot of these kids end up with pretty severe lung disease, regardless of whether they meet that number. So once they realized you couldn't just fuse them when they were 6 or 5, the idea was to make the box bigger, and that was traditionally growing rods or rib-based distraction like the Vector device. But then we learned if you start early with these distraction-based surgeries, you're going to have more surgeries. And if you have more surgeries, you have more complications. And there's also this idea of diminishing returns. And you all know this, you see kids with EOS. Every time you get in there, there's a little bit less expansion. And so the idea was to try to delay a little bit longer before you're putting in that primary instrumentation. These worst results with going early were confirmed in the Vector or the rib-based distraction cohort. And then more recently, it's been confirmed in our MCGR, or magnetically controlled growing rod cohort as well. Only 20% of the rods reached about 80% expansion in this large PSSG study. And this was presented by Suk and Shah at Posner just a couple months ago in Nashville. Pretty, not surprising study, but really stark to see this data that they were only getting 1.5 centimeters out of their second set of magic rods at $18,000 a pop. So 36 for the pair. So where am I going with this? It's really that once you're down that distraction-based pathway, the spine and the chest are going to become much less pliable, and there are diminishing returns with time. So surgery should be your last resort in this population. Certainly there's going to be kids with hemis. Often surgery at 3 or 4 years of age is effective. Deal with it then. But most of these kids you really want to be trying to delay. So if not surgery, I would propose casting as a viable alternative. The renaissance of cast treatment for early onset scoliosis kicked off in 2005 when Miss Mehta presented this paper. She showed really incredible results at about 10 years follow-up in kids with idiopathic early onset scoliosis, but also a bunch of other heterogeneous diagnoses as well. Deciding who to cast can be tricky because, as we all know, kids presenting less than a year of age with scoliosis often get better. And this is a big criticism of cast treatment. Are you over-treating? Are you treating kids who are going to get better anyways? They don't all get better. And in most of the studies that have been done more recently, the kids have been confirmed to have progression. They're worsening prior to the initiation of cast treatment, but it's still a pretty common criticism. I think it's important to initiate early treatment as well because the window for successful treatment, as you're going to see in a minute, really isn't open forever. So other ways to predict whether these curves will get worse when you see them in your clinic: the rib vertebral angle difference measured at the apex of the curve. If the RVAD is more than 20 degrees, 80% of them will get worse. Conversely, if the RVAD's less than 20, 80% will get better. It's important to remember you're going to be wrong 1 out of 5 times in those situations, so you still have to follow those kids closely. This isn't a see you in 6 month kind of thing and see what happens. You have to follow them closely. If you look at the phase of the rib, which refers to the position of the rib head over the vertebral body, if it's overlying the vertebral body, it's a phase 2 rib. That means there's a lot of rotation, and those always progress. So there is the option of treating these kids with bracing. I often would characterize that as evidence versus anecdote. Some kids may get better in a brace, but there's pretty clear studies at this point in time that's showing casting's far superior. So not equipoise here. I do sometimes use a brace for a kid presenting prior to a year of age if they're not particularly strong. If they have a big curve, say 50 or 60 degrees, and they're 6 months of age, I don't know if that's resolving or going to continue to get worse. I might use a brace so that we're not doing nothing. But you make the decision to cast relatively early. This is a characteristic case, 8-month-old female, 52-degree curve, progressive, phase 2 rib, RVAD, suggestive of further progression. Here she is, 11 months of age in her first cast, really flexible, and she had 6 casts over 14 months. Small curve at 2 years of age, braced for a year, and then here she is at age 10. This is a patient of Dr. D'Souza in Salt Lake City. So this is sort of the gold standard. I mean, this kid otherwise would have been looking at growing rods and then eventually a spinal fusion. This is sort of how you do it. We call it metacasting eponymously, but it's also called EDF, or elongation, derotation, flexion casting, or it's a lateral flexion, not a flexion forwards. And this concept was devised in the 60s by Cottrell and Morel in France. So we're tractioning the kid out, and then you need 3 sets of hands in order to put on an effective cast. There can be some temporary restrictive lung disease, so you have to hustle a little bit and then make your appropriate cutouts. This girl on the edge, she's a patient actually from Hawaii who went to Salt Lake to be casted by Jacques about 10 years ago. And I imagine she's in Kyle's clinic, and you're probably seeing her in follow-up now over at the Shrine. But yeah, she did great. And you can decorate the casts very cutely, which matters in peds. It may not matter so much in adult spine surgery. So we published this a couple of years ago. This was the first intermediate term follow-up of casting patients other than Mehta's work, looking at Jacques' cohort from Salt Lake. And what you see is that about half of the kids at final follow-up of a mean 8 years had a curve less than 15 degrees. So about half of them were cured. 3/4 of them had at least a 20-degree improvement in their scoliosis, which is pretty substantial. We followed this up with this paper, which I finally got around to writing up. After leaving academics, you lose the impetus to work on papers and stuff, which is pretty great. But we published this last November or December, 2-year follow-up after the end of casting from 5 Shriners hospitals. Lots of patients. This is the largest casting study. And notably 138 idiopathic kids, because idiopathic kids are very different than our other non-idiopathic populations, syndromic and neuromuscular. And so when we conceptualized this study, we looked at 2 and under, 2 to 3, 3 to 4, and then the older kids. And then the data was pretty compelling, but then subsequently we reanalyzed it looking at those less than 18 months of age and were really surprised. We had 5 years of follow-up on average after the end of casting, and they all had pretty big curves. Not all, but on average, pretty big curves. The less than 18-month group had a mean curve of about 47 degrees. So again, big curves. This is the key slide. When casting was initiated prior to 18 months of age, it was wildly successful, and nearly 3/4 of the kid had a major curve less than 15 degrees at final follow-up. So those kids are going to be braced for a bit, and then most of them, not all of them, are probably never going to need to have anything else for their spine. It's pretty impressive. This is the Hutter-Volkmann principle that Dr. Launer was referring to. These kids are growing really fast early on, and then as they get older, it's going to slow down. And we see that when you look at the 18 to 24-month-old group, because only 36% of the kids had what we would quote-unquote call a cure. 57% still improved at least 20 degrees at final follow-up. Very worthwhile, but it's much less consistent. So that's why making that decision really early is really important. Results are very similar in the 2 to 3-year-olds, and then in 3 to 4, they start to fall off a little bit. It's nice having these numbers because you can give parents more data and say, you know, your odds are about 1 in 4 that you're going to be cured with casting, about 1 in 3 that we can get at least 20-degree improvement at mean 5-year follow-up. I find it helps patients make their decisions better. Over 4, there was one kid who had resolution of his scoliosis with a 60-degree curve. He started at 5 or 6, but the vast majority of time, you're just buying time in this situation. So casting's most effective in younger children with smaller curves. The ideal is prior to 18 months of age. So you really want to make your decision early. And if you don't do this, get in touch with somebody that does. Make sure that referral can go in early so you can take care of these kids well. Which kid is going to respond to casting is often surprising. The largest kid in this series who had a resolution had a curve of 80 degrees. And a lot of people would say, don't even bother to cast that, but it's surprising, give them a chance. I often tell parents to look at this in 6-month intervals. Let's see where we're at in 6 months. Let's see where we're at in a year. And it sounds like a long time, but I think given the alternatives, it's very worthwhile. This is a kid that we just stopped casting. She's now 5. She has a congenital curve. She's really chill. She's from the North Shore of Hawaii, and she lets my partner, Dr. Burkhalter, put these casts on awake in the clinic. We're just buying time in this population, in this type of an example. She's going to need surgery probably in the next couple of years, but this is 100% brace compliance. So casting's great, delay is your friend, but sometimes you need to do surgery. Again, if you don't create some space for those alveoli to grow and to multiply, they're never going to. And so you often have to do something in order to open up the lungs. I consider non-fusion surgeries in kids with EOS at around 70, sometimes 80 degrees. But the age, the rate of progression, their flexibility, their physiologic demand, those are all key variables. If I have a kid who's super low demand, I might just push them a little longer and go on to an early fusion. I prefer distraction-based, but we've been doing some growth guidance over the last 2 years, and I'm intrigued and it's interesting, and we've had some good results. I'm a huge advocate for an early fusion for the right patient, and there was a recent article defining what a tweener is, those patients that you could go either way with something that's growth-friendly versus an early fusion. So these are just some tips from somebody who was relatively high volume for this EOS, but now being back in Hawaii, I think we share it a lot more amongst the 2 hospitals. So no longer high volume, grain of salt. I like ribs proximally for smaller kids. I think it stays off the spine and it avoids autofusion. You're also not fussed if they pull out. You can build an outrigger. You can go up another level, and they're really easy to revise. Remember that you need a flat sagittal segment for your MCGR, otherwise it's not going to work, and you have to respect the kyphosis. You have to go with it, otherwise you'll be revising your proximal fixation. Dr. Vitale has talked about 5 to 6 fixation points proximally, which I think is good advice regardless of whether you're going on the ribs or the spine. And I'd like to often but not always make some sort of a near circumferential construct on the top just to make it a little less likely to pull out. And remember to load each rib from the bottom up. I'll use screws for bigger kids. I haven't used navigation, but I think it would make it a little easier in some of these small kids. Often a CT scan can help you decide whether you think you can make that shot or whether hooks, if you want to go to the spine, or ribs are a better option. So remember that the correction you get at the time of implantation is probably similar to what you're going to get at the time of final fusion. They're auto-fused by the time they get older. They're not moving a whole lot. You're often just taking out your hardware, maybe getting a little bit better correction, and then putting something else in. It's often very, very underwhelming. And so because of that, I have a lower threshold for using halo gravity traction. For non-EOS kids, you got to be in the triple digits, over 100, because we have other alternatives like temporary spinal distraction for those big curves. But for these kids, I mean, even for an 80-degree curve, I might consider a couple weeks of halo gravity traction, get as much as you can. You're not going to get a whole lot more 5, 6, 7 years down the line. Again, you get one good set of magnetically expandable control rods. This was presented at POSNA. Haven't seen it in print yet. But really only 2 centimeters of growth from the first set of rods, because the other 2 centimeters was at the time of implantation, and then 1.5 centimeters over 2 years for that second set. So I think delaying is really important. And then the question people are asking now is, do we have to go back to some sort of mechanical distraction after you've placed MCGR the first time, just to get enough push force? Just a few case examples real quick. 6-year-old kid used screws. I like to do my own ultrasounds, and then you can sort of titrate the lengthening, so you get a little bit, get a little bit more, get a little bit more, and just check and recheck it. It doesn't take too long. This is a great example, just sort of a beware of this from one of my partners in Utah. This was a big, big boy with progressive idiopathic scoliosis. He got magnetically expandable control rods, a great example of respecting the kyphosis and not trying to pull him back too much. But he was so big that they couldn't couple the actuator to the rods, and so he had to be switched to a Vector device. So early fusion is an option for that tweener. I think the advantage is it's a one-and-done surgery, better deformity correction at the time, growth-friendly, more surgeries, more unplanned return to the operating room, and typically there's going to be worse deformity correction. There was a paper from China, from Beijing, I just read in the last couple of weeks, published maybe a month ago in JBJS, where they had these incredible results for predominantly idiopathic EOS, but also congenital kids. And I just haven't seen similar results to that in North America yet, but if we could do that, then I would be a bigger advocate for growth-friendly surgery as opposed to an early fusion. It's a very patient and family-dependent decision. Some families, especially here in Hawaii, are very open to the idea of let's just get it done and let's get on with our lives. Don't have a good option yet. I think we're waiting for something. I don't think tether's the option. I was hopeful about a different distraction device maybe being the option for these tweener kids, but I don't know that that's it either. This is just a neat case example. One of my partner's patients, he didn't want to fuse it. I was telling him we should just do an early fusion. This kid has spastic quadriplegic cerebral palsy, a reasonable sized curve, and it's just going to get worse. But he wanted more thoracic growth. So what we did was a fusion from L1 to the pelvis, and then didn't fuse it above that. These screws can slide, the approach is off the midline, and there are follow-up films showing that she's continued to grow, so it's working well so far. I don't know what's going to happen if she grows off the rods on the top, though. This is just one final case, a kid we did about 5-6 months ago, just under 3 years old, arthrogrypotic. He also has a T10 hemi, and while he's trach and vent dependent, he's really bright and communicates with adaptive devices. He's got a pretty big rigid curve because of his arthrogryposis. Here's his T10 hemi. It's only anterior. So the plan was a thoracoscopic hemivertebrectomy, a short posterior fusion, and then an MCGR from ribs to pelvis to try to correct the bigger curve. So just taking out the hemi, doing a little fusion, and then rib hooks, pelvic saddle. And, low 70s to 38. He's got arthrogryposis. He's pretty rigid. I wanted more, but we just lengthened him a few weeks ago and managed to get quite a bit more correction on that first lengthening. So, he's 3.5 now. There's a really long road, but the alternative, again, in these infantile or early onset kids, the alternative for this child is early death due to restrictive lung disease. So sometimes you have to go early, and just be creative. So casting can resolve scoliosis in 30 to 70% of kids with idiopathic EOS. Again, the results are much less good in other populations, but it can be a very effective delaying mechanism. The age you start treatment is key. You got to do something prior to 18 months of age. And if you get them at 18 months of age, hustle and get going on them as quickly as you can. In most cases, casting can still delay the need for surgery regardless of etiology. When these kids do need surgery, I think the problems are really interesting and complicated. This is my favorite part of pediatric orthopedics because each case is unique. And having a lot of different tools in the toolbox is really helpful, and it's helpful to think creatively. These are the cases you just sort of sit down for half hour, an hour with your partner and just make stuff up back and forth. But that's it. Mahalo. Can I ask a question first?
Yeah, go ahead.
Dr. Launer, would you tether kyphosis? Because I've got a couple kids. They're like 8, they're 9. They've got 90-degree kyphosis. And for Schurman's, I've had great success with aggressive bracing and exercise. It's not scoliosis, right? We can make Schurman's kyphosis better. And we want to put in tethers for kyphosis, but I'm worried that's not allowed.
Well, it's not allowed, but you're allowed to treat patients and discuss it with families and do things off-label. It's
Right.
probably a little trickier with an HDE device, but I think it's still done all the time. I love the idea. I think there is a series out of somewhere in Turkey. I don't think it's Ahmed Alane's group, but a group
Okay.
has reported on a dozen or so cases. So look that up, and
Yeah.
I think I'm looking for the right patient as well. But I agree also bracing for those patients can be quite effective, but obviously when you get beyond a certain curve size, so I think it's a great idea.
Okay.
Let me know when you do it. My question for you was, I don't know if you're familiar with the posterior dynamic distraction device.
That's what I was hoping was going to be the interim thing.
Yeah. Right now it's only approved for adolescent onset, but I think there was a study ongoing in Europe. I'm not sure if that's continuing for earlier onset. So are you familiar with any of that data?
I'm not familiar with that data. We're approved to put them in. I'm more of a tether guy. If I have a patient that wants to keep motion and they're older, it's between tether and that other device, I'm much more comfortable with the tether. I was hoping the distraction device would be that in-between thing. And then there was that paper presented at POSNA a couple months ago that, I don't know, I'm in holding pattern for whether I want to put that in right now.
I didn't see that.
It was from Singapore, I think. It was just, it was interesting results.
Yeah, I mean, there's a registry.
I understand, yeah.
in
I've
the
seen
US,
that too.
And the revision rate's lower than with tether.
Yep.
And some very promising results, so I think time will tell. But EOS is a much different group, so.
No, I think it still makes sense, and there still might be the right kid because I think it's better than magnetically expandable control rods. You could potentially use it. This is totally off-label. Please don't do this. But like you could use it for a couple of years, get them where you want them, guide their growth, and then just take it out. It'd be fantastic. Yeah,
Exactly.
Waiting for the right kid. But I'm a little leery from that paper I saw at POSNA.
Talking about it at the luau.
Sure.